The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies. But I could. Big Pharma, where you at? But, alas, I have no financial disclosures. Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Today I'm going to talk about something I don't really want to talk about, which is insurance. I did an episode on this a while back, but I don't think I really covered a lot of specific kind of information. I think it was mostly just me complaining about having to deal with insurance. And I'll do some of that today as well. But today I specifically want to talk about Medicare and Medicare Advantage. I mostly work with older people, so I'm going to say that's mostly what we end up dealing with on a day-to-day basis. And it's kind of a confusing thing that I don't really know much about, and I have the impression that a lot of patients maybe don't know that much about it either. There seems to be a lot of confusion about why things cost money and how to go about getting things paid for. So maybe this will be helpful. I'm not an expert in any of this. Please don't base any of your personal insurance coverage decisions on the information I'm about to present, but my goal here is to give a fairly concise overview of what Medicare is and then what the Medicare Advantage plans are. I hate that we even have to learn about this stuff. I've always been of the mindset that I'm a clinical person. My job is to take care of patients, and there are other people around whose job it is to figure out how to handle the money part of this. Now that I work for a very small practice, I'm closer to all the billing and insurance stuff than I've ever been before. And while I still don't think that clinical people should have to spend our time dealing with insurance stuff, the fact is that's what's often the most important thing to the patients. You know, if I can find a way to get somebody on a medicine for cheaper to save them money, I might be doing them more good than I would be by picking up on some rare diagnosis or even just doing routine things for them. Because in our American healthcare system, the way that things are set up, if you don't have insurance and or money, you're kind of screwed. And I don't like that. I don't think that's how it should be. I think we could do better as a country if we really wanted to. In my personal opinion, we have decided that healthcare is a privilege, not something that everybody's entitled to. And that's how the whole thing is set up. I think we should just have nationalized single-payer healthcare system, and that should be the end of it. But that's my personal opinion. And I know there are reasons why that's not everybody's favorite idea. So my objective is not really to get into any of that today. Just want to throw that on here for the record. I don't know anybody that's really happy with the current healthcare system from a financial point of view, other than, I presume, insurance companies. To me, it seems like patients and people who work in healthcare all get screwed. So anyway, okay, I digress. All right, focus. Let's start with what is Medicare. The bill that created Medicare and Medicaid was signed into law on July 30th, 1965 by President Lyndon Johnson. So essentially, Medicare is health insurance provided by the government. It is for people who are 65 and older. People will get on it earlier when they have disabilities, if they have end-stage renal disease or ALS. It's sort of connected to Social Security. If you apply for Social Security, or if you're a railroad person, there's a separate railroad retirement board for that. If you apply for one of those things at least 4 months before you turn 65, then you automatically get Medicare when you turn 65. If you're not planning to get Social Security or Medicare benefits when you turn 65, then you have to apply for Medicare separately whenever you decide you want it. And you definitely see a lot of people who are over 65 who are still working full-time and still have their insurance coverage through their employer who are not yet on Medicare. Medicare is divided into Part A, which is hospital insurance. So this covers inpatient hospital stays, care in skilled nursing facilities, hospice care, and some home health care. Part B, they refer to as medical insurance. So this is outpatient stuff. This is doctor services, outpatient care, medical supplies, and preventative services. And then you have Part D, as in Delta, which is prescription drug coverage. Part C is what they call Medicare Advantage. We'll talk about that separately in a bit. So when you sign up for Medicare, you're signing up for Part A and Part B insurance. That does not include Part D, the drug coverage. So if you're doing traditional Medicare, you sign up for your Part A and Part B, then you have to decide on a plan for your prescription drug coverage if you want that. And those come from private insurance companies. There's also a thing you can buy called Medigap insurance, which is a supplemental policy you can buy to help lower your out-of-pocket costs that are associated with Part A and Part B Medicare. So what are your out-of-pocket costs for Medicare? For Part A, as long as they and or their spouse paid Medicare taxes for long enough, which is usually about 10 years at least, right? Medicare tax comes out of your paycheck. The general theory being you pay into it while you're working and then you get the benefit back once you go on Medicare. So as long as somebody paid that Medicare tax for at least 10 years, you or your spouse, the premium for Part A is zero. If that's not the case, if somebody didn't pay into the system for long enough, you can buy it. And typically that either costs $311 or $565 a month, depending on how long you did pay into the system. The deductible for Part A, and this is something that people don't seem to understand, the idea of a deductible. This is what you have to pay out of pocket before your insurance kicks in. So with Part A, currently, the deductible is $1,736 for each inpatient hospital benefit period before Medicare starts to pay. What, you might ask, is a hospital benefit period? The benefit period starts the day that you are admitted as an inpatient and ends when you have not gotten any inpatient care for 60 consecutive days. So when you get admitted to the hospital, your benefit period starts. 2 months after you've not had any inpatient care, the benefit period ends. So for that whole period, your Part A deductible would be $1,736. If you get admitted again on day 61, now you owe another $1,736 because it's a new benefit period. And there's no limit to the number of benefit periods you can have in a year. So if you go into the hospital or into a skilled nursing facility, your deductible is $1,736 each time. There's no out-of-pocket cap or limit. There still is cost sharing, by the way. It's not like once you meet the deductible, you pay nothing. In general, with Medicare, you're paying 20% of whatever the total cost is. So they're paying 80%, you're paying 20%. For an inpatient stay, after you've met your deductible, your Part A deductible, the first 60 days, you don't pay anything out of pocket after that. From days 61 to 90, you pay $434 out of pocket each day that you're there. And from days 91 to 150, you're paying $868 a day. And apparently there are only 60 lifetime reserve days that you can use. I don't actually know what that means. It doesn't really say. I'm just looking at Medicare's website here, but that's what it says. And then after day 150, you pay all costs. So you really don't want to be admitted past 150 days if you can help it. I mean, there are multiple reasons not to want to be admitted somewhere for 150 days, but after day 150, it's all on you, or it's all on the patient. That drops to 100 days in a skilled nursing facility. So the first 20 days in a skilled nursing facility, the out-of-pocket cost is zero. Days 21 to 100, it's $217 each day. And beginning on day 101, you pay all of the cost after that. There's not usually out-of-pocket expense for most home healthcare services. For durable medical equipment, so this is wheelchairs, walkers, hospital beds, etc., the patient pays 20% of the cost for those things. Most hospice is zero out-of-pocket cost for the patient. There can be a $5 copayment for each prescription medication or other things that are used for pain relief or symptom control, and you pay 5% of the cost of inpatient respite care. So that's all for Part A. You can see why this is confusing, right? There's a lot of numbers going on here. For Part B, your monthly premium depends on your income. And I believe I touched on this during the Healthcare Under Trump 2.0 episode, if I'm remembering that correctly. But the premiums range from $202.90 per month to $689.90 per month. The highest income bracket is an individual making $500,000 or more per year, or married filing jointly making $750,000 or more. So I would say these are pretty generous increments. The lowest premium, the $202.90, applies to individuals making $109,000 or less per year. Married filing jointly making $218,000 or less. So you have to be making a pretty good chunk of change to have to pay the higher premiums, I would say, for Part B. The Part B deductible is $283, and you only have to hit that once a year. So that sounds like a better deal than the Part A deductibles. And then after the deductible, you're still paying 20% of whatever things cost. Patients generally not paying anything for laboratory services, for home health care services, still 20% of the cost of durable medical equipment, 20% of the cost of physician services while you're inpatient. This is another thing that people tend to be unpleasantly surprised by is you get a bill from the hospital for your hospital stay, but then you start getting bills from the individual doctors who saw you, which is a separate thing. 20% of the cost of outpatient mental health care, generally 20% of inpatient mental health care services, 20% of the cost of outpatient hospital doctor's care, plus copayment to the hospital for each other service that you get. So that's Part A and Part B. Part D, prescription drug coverage, these are private companies, so cost varies. If you make a lot of money, you owe Medicare a little bit extra in addition to your plan premium. So if you're one of those highest bracket $500,000 or $750,000 income people, you pay an extra $91 a month in addition to whatever your plan premium is. And then if you do a Medigap policy, the cost of those varies as well. So if you worked for long enough to get a $0 Part A premium and you make the amount of money that most people probably make, your premium for Part A and Part B together is going to be $202.90 a month. And then if you do a Part D plan, it's whatever that cost is. According to Google's AI overview, the average monthly premium for Part D plan currently is about $34.50. So my impression is that what most people on traditional Medicare do is they have their traditional Medicare, they have their Part D plan, and then they have a supplemental plan from a private company that covers the out-of-pocket costs. I'm pretty sure that's what my parents do, and they have reported to me that that has worked very well for them. They've both had some big surgeries and hospitalizations and things, and I don't think they've really had to pay anything out of pocket for any of that with their setup. So anecdotally, that seems to be how that works in practice. Now, Medicare Advantage, aka Part C, is how Medicare refers to these things internally. This is pretty much the government contracting out Medicare to private insurers. The term came about in 2003 with the Medicare Prescription Drug Improvement and Modernization Act, also known as the MMA. Oh, that's funny. So if I speak out against Medicare Advantage plans, that makes me an MMA fighter, right? I can claim that? Okay, sorry. So the federal government pays a set amount of money to these private insurers for them to handle what Medicare would otherwise be doing, which kind of, in theory, makes sense, right? If you're the federal government trying to find ways to save money, the idea of paying a flat, predetermined rate for people's Medicare seems like it could be a better idea than just paying whatever people happen to need for their healthcare services. However, in practice, and this should not come as a surprise to anyone at all, the government actually pays more to the insurance companies than what it would usually cost them to pay for people's healthcare. So according to this article from Kaiser Family Foundation from November of 2025, this whole Medicare Advantage thing actually has never saved Medicare any money. According to the Medicare Payment Advisory Commission, also known as MedPAC, which sounds kind of cool, in 2025, payments from the federal government to Medicare Advantage plans exceeded what they would have spent on traditional Medicare by 20%, which translates to $84 billion in additional spending. So if you look at this whole thing from that angle, I would say that means that it's not working as it was intended to work. Apparently, more than half of people who are eligible for Medicare are choosing these Advantage plans. I think 53% was the most recent statistic that I saw on this. And that part does make sense because when you look at the actual out-of-pocket costs and savings for patients, in a lot of cases, it does seem to make a lot more sense to go with a Medicare Advantage plan because they're cheaper. The upfront cost is cheaper, at least. There's an article here from November of 2024 from USC, University of Southern California, comparing people's monthly out-of-pocket costs on Medicare Advantage versus traditional Medicare. If I'm reading this right, the data go from 2014 to 2020, and over that time, it looks like the savings and out-of-pocket costs were about $100 to $130-ish per month. So it makes sense why a patient might choose a Medicare Advantage plan. Probably the biggest downside from the patient's point of view is that you can't always see who you want to see. Almost everybody takes Medicare, but on the Advantage plans, you have that whole situation of in network versus out of network. And really, if you think about it, I'm not an economist, but the economists that I've listened to talk a lot about incentives. You think about what the incentive is for a person or an organization to do something, and that helps you understand what they're going to do or predict what they're going to do. So if I'm knowledgeable provider, private health insurance company, and the government pays me whatever, $1,000 a month to turn around and pay for your healthcare expenses, well, my incentive is to pay for your healthcare expenses as cheaply as possible so that I can pocket the difference so that I can make a profit. I don't think I'm getting out over my skis there. That seems pretty straightforward. So private insurance companies do what private insurance companies do. They try to drive the cost down as much as possible. So they have their network of providers and hospitals and whatever different services that agree to charge them less or accept less money. And we definitely have lost patients who have decided to go with a different Medicare Advantage plan that we're not an in-network provider for. As far as other costs, you still have to pay the same premium for Part B services that you would. And then after that, it's just up to the plan. And some of these plans may have incentives where you don't pay anything additional, and then some of them actually will cover that Part B premium as well. So that can be a big monthly cost savings for the patient. One of the big differences is a yearly out-of-pocket limit. So with traditional Medicare, again, there's no cap on what you may end up having to pay if you have some kind of catastrophic thing that you have to go through. With the Advantage plans, there is an annual limit. So there is a point where once you've shelled out a bunch of money for whatever, you don't have to pay anything else for the rest of the year. Most of these Medicare Advantage plans include Part D coverage also. So you do not have to buy a separate Part D plan with most of these. Whereas traditional Medicare, you have to have your drug coverage plan purchased separately. As far as the Medigap plans, these are the private supplemental plans you can buy with traditional Medicare. You cannot buy those if you're on a Medicare Advantage plan. As far as what these plans cover, they're required to cover the same things that traditional Medicare Part A and Part B cover. But outside of that, they can really do whatever they want. So some of these plans offer different little benefits like gym memberships or a health savings card that gives you extra cash to pay for medical stuff with. Some of them cover transportation. Some of them will cover home meal and grocery delivery services. That's pretty cool. And some of them cover additional services that Medicare does not. So that would be like vision stuff, routine vision stuff, hearing aids, dental care, and annual physicals, which Medicare actually does not cover. So it sounds pretty good from the patient's end. On our end of things, of course, that means we have to deal with a lot of the nickel and diming that private insurance companies do that Medicare does not. So that's prior authorizations for things that the patient needs. We have to mess around worrying about, are they going to cover this or are they not? So we can figure out what we're going to do. Lots of back and forth fighting with them to try and get them to cover things that we want them to cover. There's a kind of a funny explanation of all this I found. This is from Salem Township Hospital in Salem, Illinois. And it's a little comparison. Well, it says it's a comparison. Really, it's all about why they hate Medicare Advantage plans. And according to this article, in 2023, the average out-of-pocket limit for Medicare Advantage is $5,070 for in-network services. For PPOs, which means Preferred Provider Organization, the average is around $9,000 for both in-network and out-of-network services. So we have conflicting information here. According to this USC article, the out-of-pocket costs are lower. According to Salem Township Hospital, the out-of-pocket costs are higher. So I think, just from what I have read, it probably depends a lot on the individual person's situation and what kind of services they need and how much of it is in-network versus out-of-network and how much care they're getting, etc. So I think that's all the actual data that I want to present here. I hope this is helpful for people like me who kind of have a dim understanding of how all this works, to help clarify what information patients are having to juggle around and considerations that they have regarding how much they're going to pay for things. My personal impression from doing all this study and knowing what my parents have dealt with seems like if you go with traditional Medicare, with a Medigap supplement and your Part D drug coverage, you probably at least know what to expect. It might be more expensive up front, but when the catastrophe happens or when you need this or that, there probably aren't going to be any surprises as far as cost. With the Advantage plans, it seems like maybe it's more of a crapshoot. It just sort of depends on which one you go with and what their specific offerings are and their specific rules and limits and things. So if you're listening to this as someone who's trying to figure out which way to go, first of all, talk to somebody who actually knows what they're talking about. Don't listen to me. But if you do want my advice, it would be very selective and careful and make sure you understand what you're signing up for before you finalize it. Because one thing that I really hate is seeing people in their 70s, 80s, whatever, especially people who are sick and need a lot of things, still having to play the whole game of nickel and diming and, oh, don't order this test that might cost $20 extra, and I don't know if I want this medicine or not because I don't know how much money it's going to cost. I hate that. Oh, it drives me nuts. That's really what I wanted to say about Medicare and Medicare Advantage. If you know something about this that I don't, that I should have covered, or if I said anything wrong, please feel free to get in touch. As always, thank you so much for listening. I hope you enjoyed the episode. I hope you have a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, and subscriptions really do help the show, so please take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.